Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hi, my name is Qian Dong. Today we're going to talk about MRI imaging of the meniscus, anatomy, and the classification of tears. I have no disclosure. Accurate and timely diagnosis of meniscal tear is critical. It requires radiologists to be familiar with imaging protocols, thorough understanding of normal meniscal anatomy, surrounding anatomic structures, normal variants, and pitfalls. Detailed MRI diagnosis of a meniscal tear, including classification of tear pattern, can guide the referring physician in patient evaluation and surgical planning. Occasionally, meniscal tears can be difficult to detect at imaging. However, indirect signs such as perimeniscal cyst, meniscal extrusion, or linear subchondral bone marrow edema should increase the radiologist's suspicion for an underlying tear. Menisci are composed of tissue called fibrocartilage. Longitudinally oriented type 1 cartilage bundles provide the meniscus with hoop strength and are critical to resisting axial load and preventing meniscal extrusion. Thinner radial fibers are interposed perpendicularly to these bundles and act to tie the bundles together. The menisci are vascularized only via the peripheral and the root attachment, and therefore the inner portion are avascular. This has important implications on the healing and the surgical management of meniscal tears. Each meniscus can be subdivided into the anterior horn body, posterior horn, and the roots. The anterior and the posterior roots typically attach to the central tibial plateau, serving as anchors and maintaining a normal meniscal position and biomechanical function. The medial meniscus is larger than lateral meniscus. On sagittal images, the menisci appear as either a bow-tie structure peripherally or opposing triangle centrally. On coronal images, the menisci appear either triangular or wedge-shaped. The circumference of medial meniscus is tightly attached to the capsule and the deep fibers of the MCL, therefore more susceptible to tears. Lateral meniscus has loose capsular attachment and lack of direct attachments to the LCL. The popliteal meniscal fascicles are synovial-lined fiber bands that attach to posterior horn and help form the popliteal hiatus. The anterior lateral meniscus root can have speckled appearance in up to 60% of patients, which is likely secondary to adjacent fibers of ACL insertion. This appearance can mimic a tear. Root tears have received increased recognition in recent years, particularly because of their previous underdiagnosis at both MR imaging and arthroscopy. So make sure you pay attention to both medial and the lateral posterior root attachment on sagittal and coronal images. On coronal image, you can visualize their attachment adjacent to PCL attachment site. Transverse meniscal ligament connects and stabilizes anterior horns. On sagittal images, this ligament can simulate a tear. Meniscal femoral ligaments originate from posterior horn of lateral meniscus and insert onto lateral aspect of the medial femoral condyle. They help control the mobility of posterior horn during knee flexion and extension. The commonly recognized meniscal femoral ligaments are the Humphrey and Weisberg ligaments, which travel anterior and posterior to the PCL respectively. Meniscal tibial ligaments, also known as coronary ligaments, attach meniscus to tibia at various locations, as seen on this coronal and sagittal examples. Discoid meniscus represents an enlarged meniscus with further central extension onto the tibial articular surface is often incidentally detected far more common in lateral meniscus than in the medial meniscus. The complete variant covers the entire tibial plateau, while the partial variant has less than 80% of tibial plateau coverage. Meniscal flaunce is a reported appearance of the free non-anchored in the edge of the meniscus, which is more common in medial meniscus and seen in asymptomatic knees. A meniscal ossicle is a rare entity with appearance of ossified meniscus and more often in posterior horn of medial meniscus. On radiographs, it can be mistaken as an intra-articular loose body. It is important to be familiar with adjacent anatomy, as interfaces between ligament, tendon, and meniscus can mimic tears as seen in the three sectional images: transverse ligament adjacent to anterior root medial meniscus, meniscofemoral ligament adjacent to posterior root lateral meniscus, and the popliteal tendon adjacent to peripheral lateral meniscus. Okay, some general rules of meniscal tears. Tears are more common in posterior horn, especially medial meniscus. Lateral meniscus are more common in younger patients with acute injury. Isolated tears in anterior horn are uncommon. In setting of acute ACL tear, there is decreased sensitivity for detection of lateral meniscus tears. Small radial tears and Barkey handle tears can be difficult to identify on sagittal images, so make sure you pay attention on coronal images as well. The diagnostic criteria meaning uses intrameniscal signal when it's extending to either superior or inferior articular surface on two consecutive sections. The diagnostic accuracy is more than 90%. When it is visualized only on one section, then it can be reported as probable tear due to decreased diagnostic accuracy. The other thing is abnormal morphology, as truncation you can see in this example. Accurate description of meniscal tear morphology and pattern is critical for treatment planning. Most common tear patterns include horizontal, longitudinal, radial, and complex tears. Horizontal tear runs parallel to tibial plateau, involves either one of the articular surfaces or central free edge. It typically occurs in relatively older patient with underlying arthritis. It can associate with perimeniscal cyst. The treatment option is debridement. Horizontal tears can give rise to flap tears, which can be seen as superior or inferior when displaced from superior surface or inferior surface of the meniscus, respectively. Longitudinal tears run perpendicular to tibial plateau and parallel to long axis of meniscus, divide meniscus into central and peripheral halves. It occurs often in younger patients with history of trauma. It has propensity to involve peripheral third of meniscus and the posterior horns. The typical MRI appearance is a vertically oriented signal abnormality that contacts one or both articular surfaces, such as in this case. There's a close association between peripheral longitudinal tears and ACL tears in both medial and lateral menisci. Ramp lesion, as seen in this example, is a longitudinal tear of peripheral capsular attachment of posterior horn of medial meniscus at meniscal capsular junction. About 12% in acute ACL tear cases, easy to miss, potential for healing due to involvement of rhizome. In the setting of acute ACL tear, far lateral meniscal attachment to posterior horn lateral meniscus equal or more than 4 consecutive slices lateral to PCL, suggestive of a meniscal tear known as Wisberg rib. Barking handle tear is another subtype longitudinal tear with central migration of inner handle fragment. It's more common in medial meniscus. Looking for a double PCL sign, diminished meniscal size, and extra low signal abnormality in intercondylar notch region. The differential diagnosis of diminutive meniscus includes post-op changes such as prior partial meniscectomy, tear with flipped fragment, as seen in this case, chronic degenerative type tearing. So it is helpful to look for prior surgical history, evaluate underlying arthritis, and search for flipped or displaced fragment in these areas. In contrast, horizontal and longitudinal tears, radial tears disrupt the meniscal hoop strength, resulting in a dramatic loss of function and the possible meniscal extrusion. They often are not repaired due to involvement of white zone, so the treatment option is debridement. Many MRI signs may indicate a radial tear. In this example, you can see a cleft between free edge and the remaining posterior horn. Okay, root tear is radial type tear. Complete root tears have high association with meniscal extrusion, particularly in medial meniscus. They are better appreciated on coronal images. On sagittal images, make sure you follow the posterior horn all the way to the attachment side. As we mentioned before, intact posterior roots are better appreciated on coronal image adjacent to PCL insertion site. Okay, complex tear is a combination of radial, horizontal, and longitudinal components, any two or all three of them. It's very helpful to describe unstable components such as radial, flap, or root components in your reports. Osteoarthritis with degenerative meniscal tears are often complex tears. The MRI appearance usually appear diminished meniscus with globally ill-defined signal and extrusion. Imaging evaluation of post-operative meniscus can be challenging as they may appear as distorted normal morphology with increased signal abnormality extending into articular surface, such as seen in this case. The tips include prior MRI study for comparison, a detailed operative report, and definite surfacing fluid signal on two or more images or displaced meniscal fragment. Sometimes MR orthography may be required to make a definite diagnosis. Okay, in summary, understand anatomy, making your own checklist. Look at all plans. Be familiar with tear patterns and pitfalls. When reporting, be descriptive. Encourage feedback from clinical colleagues. Thank you.